So today we'll be talking about decision making and fracture distal radius. Fracture distal radius is one of the commonest fracture we see in emergency and treat in our OPD. In this talk, we'll be limiting ourselves to decision making rather than techniques, and though we'll touch upon some technique, but how to choose different methods, we'll be talking about that. If we see literature, Schoen in 1990 reported 20 to 30% unsatisfactory results in anatomical and functional outcomes. This was because there was a high incidence of malunion in fracture distal radius when treated non-operatively. There was a radial shortening and there was a articular incongruity. Before we start, we must all agree on few things. Don't want to discuss that in metaphysical fractures, the alignment is important. Length should be maintained, and there should not be any rotational malalignment. For intra-articular fractures, I must say that absolute and anatomical reduction is a must, and there should be early rehabilitation so that we can have good functional results. So for these, three steps are important, vital. Achieve reduction. First thing is we have to achieve reduction. Maintain that reduction, because if we achieve a reduction and we are not able to maintain it, then there will be malunion. And we should be able to early rehabilitate the patient to get good functional results. How? Anatomical reduction should be achieved, and there should be whatever reduction we have achieved, it should be stable, whether by fixation or by plaster cast or any method external fixator. Whatever reduction we have achieved, it should be stable. And in this process, we should try to preserve as much as blood supply, because blood supply is needed for fracture healing, and that is what we call biology of the fracture should be maintained. And we should have early and active mobilization to get good functional results. Whenever we are treating fractures, any fracture, that there are three main points. One is fracture configuration of fracture geometry, which is not under our control, but fracture geometry many times guide should be the line of treatment. We'll be discussing that. Patient factor is also important. Suppose patient is a smoker, then chances of non-union are high. Suppose patient is osteoporotic, in such cases, implant failure rates are high. Or patient is non-compliant, he is not following the rehabilitation protocol, then functional results are compromised. Third thing is surgeon. Surgeon factor is very important, because surgery is not like a prescription of a drug. You write a prescription, write a surgery, and surgery is done. It all depends on surgeon training, surgeon technique, and surgeon's experience. Along with it, it is also required that availability of implants and techniques and instruments should be available to the surgeon, because if surgeon is in a remote area where implants are not available, even he is a very experienced surgeon, he won't be able to do justice to the treatment. So these three factors are very important. So as we can see in this slide, not all fractures of lower end radius are similar. Some are volar bottom, some are comminuted, some are undisplaced, some are displaced extra-articular fracture. Therefore, the treatment for lower end radius cannot be treated by same or single method. Like there is no single key for all locks. So according to the fracture configuration, the treatment has to be done. So this is what we are going to do in this part of the talk. Suppose patient comes to us with the fracture distal radius. Either fracture is displaced or undisplaced. If fracture is undisplaced, then we treat them conservatively in a cast, below knee cast or below elbow cast or above elbow cast. That depends on what is the fracture configuration type, whether ulna is involved or not, DRVJ is unstable or not. So this is will depend on that fracture type, but you can treat them conservatively. If fracture is minimally displaced but position is acceptable, then we can again treat them conservatively. If fracture is unacceptable, we do a close reduction. After close reduction, if fracture is reducible and stable, we treat them in a cast. But fracture is reducible, it is reduced but unstable. How do we define unstable fractures? Fractures can be unstable upon radiology if there is a significant combination, if there is an angular deformity more than 10 degrees, or shortening more than 5 millimeter, or articular displacement more than 2 millimeter. In such unstable fractures, once you have reduced, you have to give stability, whether you're giving external fixation, percutaneous pinning, or open reduction, internal fixation. So unstable fractures should be supplemented, otherwise you'll lose reduction. One of the common ways to achieve reduction is percutaneous pinning. Percutaneous KYs, they are good when fracture is stable, or you can say when it is a two-part fracture and you reduced it, so you fix it with cross KYs. But we must understand, whenever we are fixing a fracture with KYs, we must supplement it either with a slab, cast, external fixator. Some kind of external support should be there, otherwise KYs are not good enough to hold the fracture till the union, and they might back out, loosen out. So, or uh, there can be loss of reduction. So after close reduction, if still the fracture is unacceptable, that means it is irreducible, such cases we have to do open reduction. And we can do open reduction and internal fixation with many ways. There are many ways to do it. But fractures like volar Barton fractures or young patients fracture, non-comminuted fractures, the buttress plating is a very good method to be used in volar Barton fractures, because buttressing can be done when opposite cortex is intact. If opposite cortex is not intact, then buttress effect does not come. So you have to have, for buttressing, you have to have a prerequisite of intact dorsal cortex. This is one of our publications from 2006, in which, or 2007, in which we talked about that if it is a volar Barton fracture, pre-contoured locking plate, they're not good implant choice. Either we should be using a Alice plate or straight plate, or if you are using pre-contoured locking plates, we should under-contour it. Unless you under-contour it, you're not going to get compression at the fracture site. So in such cases, you should under-contour it, and there's no need, it's not necessary that we should have fixation in the distal fragment, but on safer side, fragment does not slip under the plate, you can use locking screws in the distal part also. But if there's a combination, or if the dorsal cortex is not intact and you're using a buttress plate, then something like this will happen. It will be a complete collapse and dorsal tilt, so complete failure of your fixation. So we must understand buttressing is not done whenever there is a combination or opposite cortex is broken. Non-locking plates are usually used in buttress mode and cases of volar Barton. Otherwise, we go for a locking plate, especially in osteoporotic fractures and comminuted fractures. The internal fixation with the locking plate is advisable. I'll just discuss something about osteoporosis. In osteoporosis, bone is weaker, the mineralized bone is less, so there are less demineralized portion. But do we think that healing is slower in osteoporosis? No, it is not slower. The healing is at the normal rate. Only thing is because bone mass is less, so mass of callus is also less. Just talk about if we enlarge the normal bone cortex and osteoporosis bone cortex, you can see the demineralized areas are much higher in osteoporosis. So purchase of implant is a problem. So in cases of osteoporosis, it is advisable to use a locking plate. We are just having, these are the videos borrowed from Synthes. Yeah. This is a spongy bone, mimicking the osteoporotic bone. So you can see when you are stressing the bone, non-locking implant fails. But if we can see if it is locked properly, then it can take care of more and more stresses. Same thing here, apple represents the osteoporotic bone. So whenever there are stresses, the implant tends to loosen out, back out, and eventually it fails. But if you're looking at the locking implant, uh, the same apple, you can put more and more stresses before it fails. So the amount of forces required are very high for implant to fail in locking cases of locking implant. Another example, we're using a sponge ball as a osteoporotic bone, and when we start mobilizing after fixation, you can see the screws start toggling, and slowly implant fails. But when you're using a locking plate implant, when you can mobilize them early, implant doesn't fail. So it is, as it is said, it is always a race between implant failure and release. If implant lasts longer, union tends to win. So locking plate are also fixed angle construct. So in fixed angle construct, these locking screws, they act as a support under the articular surface. So this is the plate, these are the screw. When they come under the articular surface, they act as a support, as a raft under the articular surface. So whenever it prevents fracture from collapsing. So it is very important. It reduces the need for the bone grafting. Suppose there are small voids in locking implants, we need not put bone graft because inherently the construct is very stable. And we have seen that fixation in osteoporotic is much better with the locking implant. This was 2004 fifth annual International Hand and Wrist Biomechanics Symposium, NEO, where it was discussed that do we really need very high biomechanically stable implants which are more than 10 times the physiological node? There were implants in which there are 3 rows distally. So I'll say it's not required. Very high stability is not required. Normal locking plates are good enough. So locking plates are useful in osteoporotic and comminuted fractures. How do we choose implant? In normal situation, most of the implants have similar result, and most of the locking implants, they have similar result. So locking construct, one thing we know, locking construct is more rigid than non-locking. We already seen. Locking construct from different companies have similar biomechanical properties. So it should not be that we should favor one company over another. But definitely variable angle locking provides more versatility. So we'll be seeing in next few cases how variable angle helps us. And there are definitely some specific designs for specific situations, and we'll be discussing few examples for this. So first, this is about an extra-articular by Synthes LDRS system, which came in 2004. Here, all the screws were 2.4, so that more number of screws can pass through the plate, giving more stability or more, you can say, support under the articular surface. The plate is put little bit proximal to the joint, and angle is towards the dorsum and distally. So if you try to bring this plate, because it's a fixed angle device, more distally, then screws are going to penetrate the joint. In such cases, there's a different plate which is called juxta-articular plate, in which plate comes very distally and screws are not as distally directing as they're in extra-articular plate. I'll say many screws, they go proximally rather than distally. So it is good for distal fractures. It buttresses as well as fixes all these distal fragments. But variable angle fixation has really changed our view. Instead of using many plates, we can use single plate for different fracture configuration. And there's a better buttressing radial and intermediate column because it is wide in a triangular shape. And there are more screws in both columns, and there are 2 rows of distal fixation. Excuse me. So variable angle, it forms a, you can say, 30-degree of cone. So it is 15-degree each side from the central axis. Just an example, 27-year-old male compound fracture, an emergency external fixator was applied, and through the ulna intramedullary wire was done. In this case, we decided there was no infection on the fifth day, and when we did a second look, we decided to do formal fixation, and at the same time, external fixation was kept alive because there were injuries in metacarpal and phalanges also, and in the same setting, resurfacing was done. I'll not go through the step, but we'll discuss in other talk about how to fix distal radius, what to do. So there was a resurfacing using a anterior lateral thigh flap, and ulna was, which wire was done. It went into non-union, and there was a DRJ instability. So in second stage, what we did a DRJ fixation by stability by using tendon graft and RF and bone grafting of the ulna. So there was another case, 37-year-old male with a distal radius fracture, comminuted fracture, and this was a check film, which made lot of residents and other colleagues worried, like what we are doing, we are putting screws into the joint, but no, that was not a problem. So everyone was pointing out towards these three screws. But when you take proper views in post-operatively, all the rays of X-ray should pass parallel to the joint surface in all views. Then we find that none of the screw is inside the joint. Let's take a closer look. Because it is a volar tilt, so volar cortex is more proximal. This is a dorsal cortex. If there is any screw in between this has to be in the joint, but none of the screw is crossing the into the articular surface. So we are safe in this. But the question comes, why should we take our plates so distally that we are worried about screw penetration? The answer is in 2006, a study done by Jesse Jupiter et al. They were very specific about that subchondral bone is the best bone there, and if we put place our screws in the subchondral bone, it provides the greatest stability to our fixation. So we try to put all our screws in the subchondral area. Therefore, the screws have to be near the articular surface, but we should not put our screws into the articular surface. Again, as we were talking about that, there is a special situation, special plates are designed. This is one of the implant, which is what we call volar implant. Again, this is by Synthes, but other companies are also, I think, bringing these kind of implant. This was one of the first implants which actually crossed the watershed line, and that is why the implant sometimes irritates the flexor pollicis longus and FDP, because it becomes little bit proud on the volar side, and we have to be very careful not putting our screws into the joint. Again, this is a variable angle plate, so there are chances that we can, if we are not careful, we can put our screws in the joint, but because of being variable angle, we can see our screws and direct our screws specifically towards the fragments and putting them away from the joint. Excuse me. As you can see, this fracture was very distal, and to buttress the distal fracture, the surgeon had to put plate just up to the lip. Unfortunately, this plate was not variable angle plate. So because of this, the screws, they went into pre-decided trajectory, which was into the joint. So whenever we are going near the joint, variable angle always helps. So open reduction, internal fixation, patients are accepting it. With the coming of Indian implants, they are becoming more affordable and more awareness coming into the patient. Surgeons are also accepting it because of low failure rates. Availability has increased because of more players are into the market, and as experience is increasing, surgeons are using more and more complex fracture fixation using a locking plate. So this is what we are doing. Before I conclude, we have to understand when we decide that we have to do arthroscopic assisted fixation. So arthroscopic assisted fixation, again, it is a very handy tool in which, because we are using arthroscopy, we can limit our acceptance to step less than a millimeter. So nearly, or we can have a anatomical reduction of the steps. But main advantage is that associated TFCC injuries can be fixed at the same time when you're fixing the fractures, so you can mobilize your patients early and more complex fractures can be treated. So this was one of the cases in which TFCC repair and fracture fixation was done at the same time. And this is an inside out technique. Again, another case, 27-year-old male, comminuted interarticular fracture. And, first, we do a temporary fixation. Then we try to build a reduction over one of the fragments which we have reduced. You can see there is a step. Then we use this as a punch, which is going under the articular surface. Lift this fracture, but still there is small amount of step. Then you do arthroscopy to reduce the fracture. You put your probe inside. When you put your probe inside and rotate it, the fracture becomes elevated. Once fracture is elevated, now you can see very carefully how well the reduction is there, where more than a millimeter step was there. Now it is almost anatomical. So after that, you put fixation is completed, and you use bone substitute to support your comminuted articular fragment. So this is the same example. You can see there was a lot of combination which you can still see, but articular surface is very well reduced. So, in conclusion, this is very old, like 2009, the GPDS, which said that distal radius treatment, it depends upon your age, upon your address. Why address? Whether you are affluent or whether you are from the major cities where implants were available. Now, I think almost whole of the US, it is a standard treatment when you're fixing, whenever you're doing open reduction internal fixation, you're using locking plate. So that wide variation is reducing with more time, but still in India we are facing that whatever fracture fixation, it will vary upon gender, age, race, or geographical region. In remote areas, rural areas, the treatment may be different, but with time more and more standardization will be there. So I'll say there's no confusion. The consensus is towards the fixation with the locking plate, but no conclusion. Why no conclusion? Because science is advancing, technology is advancing, and they'll all these meta-analysis, they'll leave some amount of doubt, because every time the study is done, the variables are different, so very difficult to say which one is best, because some people, because of the experience, will have better result with different type of treatment. So though there is no conclusion, but the consensus is that locking plate internal fixation is a better than non-locking fixation. I'll thank you. These are like Loftus and Andrew Palmer, who helped me to understand wrist arthroscopy. Thank you very much. Now I'll ask uh, Akram, any comments or questions? Ankit, Hiba, yeah, Ankit, you unmute yourself. Yeah.
Yeah. So the first I wanted to ask you that when we talk about the Orbe's watershed line, as he had originally described, it was an imaginary line uh, beyond which the chances of the
No,
tendon.
it's not an imaginary line. Actually, if you see on the bone model, you can see the watershed area. And when you're doing a surgery, the capsule attachment is on the watershed line. So you can easily demarcate that watershed line.
Secondly, sir, I wanted to ask you if there is a comminuted fracture, what is the difference between a locking screw or a peg in that particular case?
See, now most of the systems, see, peg started with the, if you really want to go into the history, pipe plate brought peg because at that time screws were not used, only pegs were being used because the theory was that in a locking implant, it is an angle fixation, you don't require a purchase. So it all depends on the core of the screw, the strength is decided. So core is highest in the peg. Plus, some people thought when you using a screw, this might disrupt the cartilage or might, when you're
Right.
screwing in, might displace the fracture. That's why peg were used. But as you see, I don't think any new system are bringing pegs. Pegs are going out, though they are biomechanically more stable because of their high core diameter, but it doesn't matter, as we said, absolute stability or is not necessary. Screws are doing the same purpose, plus you're reducing your inventory also.
So thirdly, what is your plan and how do you go about it fixing the enlarged toilet fragments associated
I
with distal
think
tubule?
we'll touch this in one of the talks. Ulnar stelloid, if DREJ is stable, then I don't think ulnar stelloid should be touched. But we'll be definitely discussing this one of the talks in near future.
Last question, sir. You talked about the prerequisite for a buttress plating is the integrity of the dorsal cortex. That the opposite cortex should be intact. What if there is like a bicortical and a significant comminution fracture? How do you go about it? Do you plan to fix the volar part first or plate it
No, we are
distal
talking
plate,
about volar. That was prerequisite for the
volar
buttress
part?
plating. Buttress plating.
Yeah.
See, you cannot buttress when both cortices are there. Though we were used to, I have some images, maybe we'll discuss this one of the talks, where you do buttressing from dorsum as well as volar.
Volar.
But with the locking plate, buttressing from both sides is not important, except for if you're not getting excess of the screw or fixation on the dorsum through the plate. See, angle fixation, if you're supporting your articular surface and it is on the volar, dorsally, if there is a void, you can avoid fixing dorsally. But there are some situations where screws are not holding, then you have to put an additional plate. That can be in a buttress mode.
Okay.
So the Ankit asked which what should be the order. Order is depending upon the stability. At what step you
Sorry,
are
Akram, your
placing
voice is not. Can you repeat, please?
it. So I was talking about Ankit's question that which approach to start if we are planning a dual plating kind of volar and dorsal plating. He wanted to know which side which you will fix
The
first.
first.
I
Okay,
would
dual
always go
plating.
for less
So that
comminuted
is
side.
another talk, but we'll say wherever you think you can access the major part of the fracture,
Yes.
you should open. The combination of fracture is more accessible to from volar side, then you open volar. If it is from dorsal side, you open dorsal. If it is equal inconclusive, then because we are using volar more often, I'll go volar first, because
Okay.
implants
So
used in volar are much steadier, much bigger. So I'll have a good fixation volar first, and maybe small amount of fixation we can do by dorsal mini plates. We can do.